Good morning, everyone. Let's start with today's topic, that is TOS Assessment and Management. Coming to the assessment part, we have something known as physical diagnostic test or special test, wherein physiotherapist performs some test to identify whether the person is suffering from that syndrome or not. So there are some special tests to diagnose TOS, whether the person has TOS or not. These are the listed tests. We'll deal one by one. First one, elevated arm stress test, also known as Roos test. The person who identified is the name of Roos. Hence the test termed as Roos test. The patient is in sitting position with the bilateral upper extremity abduction to 90-degree, whereas the elbow is flexed to 90-degree flexion. He or she, that is patient, is asked to do fisting and unfisting tightly of both hands simultaneously for 15 times. Any numbness, cramping, weakness, or inability to complete the repetition is suggestive of TOS. This is how the patient might demonstrate in front of you the test. Patient is twisting and untwisting very tightly. This is suggestive of TOS syndrome if there is subclavian artery blockage. Coming to, or even this can also be related to brachial plexus blockage or compression. Coming to the second test, that is your Adson test. The patient here is in sitting position, whereas the therapist is in standing position behind the patient. The therapist abducts the patient's arm to 30-degree and maximally extends the shoulder. The radial pulse is then palpated. It's not felt, it is just palpated by the examiner who grasps the patient's wrist. The patient is asked to turn actively his head ipsilaterally, take a deep breath, and hold it. The therapist feels the radial pulse then and compares it on the contralateral aspect, that is your normal side. If there is any diminution or disappearance of the radial pulse seen, this is a suggestive of TOS. This is especially done in the presence of subclavian artery blockage in TOS. This is how the test might look. Coming to the third test, supraclavicular pressure test. The patient is seated with the arms in the side. The examiner places his fingers on the upper trapezius and thumbs on the anterior scalene muscle near the first rib. Here, in this test, the therapist can either stand in front of the patient or behind the patient. In the image, as you can see, this is a patient in seated position. The posterior muscle is upper trapezius, the anterior muscle is your scalene muscle. If the patient is standing posteriorly to the patient's index finger and the middle finger should lie anterior to the scalene, whereas your thumb should lie posterior to the upper trapezius. Compression of both the both the parts of the hand, that is your thumb and the index and middle finger towards each other for 30 seconds. This is known as supraclavicular pressure test, wherein both upper trapezius and scalene muscle are compressed together. This pressure is held for 30 seconds. If there is any kind of symptom arising on the side of the syndrome, the test is diagnosed as positive for TOS syndrome. Coming to the fourth test, that is your Costoclavicular Manual. This test may be used for both neurological and vascular compromise. The patient brings his shoulder posteriorly and hyperflexes his chin. A decrease in symptom means that the test is positive and that the neurogenic component of neurovascular bundle is compressed. Coming to the last test, that is your cervical rotation lateral flexion test. As the name suggests, the patient is sitting comfortably on the chair, whereas the therapist is standing behind the patient. He grasps the head of the patient and laterally rotates it towards the opposite side. While maintaining this position, the spine is gently flexed as far as possible, moving the ear towards the chest. The test is considered positive when the lateral flexion movement is blocked or restricted compared to the normal side. This is suggestive of TOS because there is a reduction in the costoclavicular triangle space. Coming to the outcome measure. These are the enlisted four outcome measure which can be used in TOS. DASH, SPADI, NPRS, McGill-Pain questionnaire. These outcome measures the severity or the amount of symptom arising or seen in TOS syndrome patients. Coming to the physiotherapy management or treatment, it is divided into two stages, that is stage 1 controlling stage and stage 2 treating stage. Stage 1 controlling stage. The aim over in stage 1 is to decrease the patient's symptom. The symptoms have already occurred. If you have to just reduce the symptoms so that there is no further progression of the syndrome. The first maneuver is known as Cyriax release maneuver. The Cyriax release maneuver is performed when there is release phenomenon seen. Release phenomenon is seen in dispute neurogenic type of TOS. The patient is in standing position. Ask him to bend his elbow and lift his shoulders up. That is, he has to shrug up the shoulder. When he shrugs up the shoulder, his upper trapezius and levator scapulae act up together, thus inducing the thoracic outlet syndrome, that is, compressing the thoracic outlet, thus producing the symptoms. If imagine the same thing is repeated in the presence of the pillow underneath the elbow. Roller towel or pillows are placed beneath the both elbows so that there is no activity of the muscle. Thus, there is no compression of the thoracic outlet. Thus, there is no symptom. This, this is known as Cyriac's release test, which may be done in release phenomenon if present. This test usually induces decrease in symptoms suddenly on performance. Ideally, the patient should maintain till the symptoms recur back. For example, if 30 minutes it takes for the symptoms to recur back, on maintenance of this position, gradually again the symptoms decrease off. Hence, this test also a part of treatment is done when the patient is falling asleep. Perform the test and then allow the patient to sleep. There is no wake up phenomenon seen, ID, which is usually seen in TOS syndrome. Coming to the second part of the controlling stage, cervical traction can be given in order to relieve the compression of the bundle. Hotmost pack can be used to achieve the sedative effect. Light exercises of shoulder girdle and cervical movement can be performed, but definitely avoided when it is chronic TOS. Breathing exercises, relaxed breathing exercises definitely help in relaxation of scalene muscle. Now we know that there is something called as muscular link occurring between or present between the diaphragm and scalene. Let's look at the muscular link. Consider this to be your appendicular skeletal system wherein you have diaphragm, rectus abdominis and transversus abdominis. We are just interested right now in diaphragm. Look at the green color part, which is diaphragm, which is directly connected with your intercostals. That is the muscles for the present in the intercostal ridges. These intercostal muscles are directly connected with pectoralis major and minor. Pectoralis minor, which is lying underneath the pectoralis major, is in direct connection with the scalene. Thus, relaxation of diaphragm will cause relaxation of scalene. This is nothing but your muscular link. This is a part of jandas. I'll be explaining in different video. Coming to the stage 2, that is treating stage. Aim in this stage is to directly address the tissues that create structural limitation of motion and compression. There are four parts of the treating stage, that is stretching of thoracic closures, strengthening of thoracic openers, aerobics or pilates to maintain the optimal length of the muscle which are stretched and opened up, posture correction exercises. Now, when we talk about muscle, there are something known as thoracic outlet closures and thoracic outlet openers. Closures are the one which close the thoracic outlet, inducing the symptom. We need to stretch the muscle to reduce the symptom. Thoracic openers are nothing but the openers or the muscles which open up the thoracic outlet. If they have undergone weakness, you have to strengthen them to reduce the symptom. So, first one, strengthening of the thoracic openers. Thoracic openers are nothing but your levator scapulae. You have to strengthen it by giving the dumbbell and ask the patient to shrug up the shoulder. There is no weight, there is definite increase in TOS symptom. Thus, give him a weight at the end of the wrist, hold the weight and ask him to shrug up the shoulder. That is nothing but levator scapulae activation. Coming to lower traps activation. Lower trapezius is also a fantastic thoracic outlet opener. The strengthening it will open up the thoracic outlet, thus reducing the symptom. These two muscles are the thoracic outlet openers. Coming to the stretching of the thoracic closers. Thoracic outlet closers. Middle scalene, anterior scalene, and pectoralis minor are nothing but your thoracic outlet closer. Middle scalene, sit erect. Contralateral side flexion is nothing but your middle scalene stretch. Sit erect, rotation, and the contralateral rotation, and then extension is nothing but your anterior scalene stretch. Pectoralis minor stretch. As you can see, the person is leaning against the wall. That is nothing but the pectoralis minor stretch. These are your thoracic outlet closers. Stretching this muscle will definitely reduce your TOS symptoms. Coming to the maintenance exercise, that is your postural correction exercises. This is your sway back posture, wherein the person is swaying backward on entirely placing entirely the head, arm, and trunk weight is on the pelvis. Thus, he is swaying backward on the pelvis. Entire his all the muscle activity, every weight bearing status, everything is COG and all is located in the SI joint. Coming to the hyperlordotic. Hyperlordotic is nothing but exaggerated lumbar lordosis, wherein your entire body is shifted front. You can look at the COG that it is lying too much behind compared to the lumbar spine, wherein your SI joint is also compromised in the hyperlumbar lordosis. Coming to the exaggerated thoracic posture or thoracic kyphosis. When you talk about thoracic kyphosis, humping up or douchebag is nothing but your thoracic kyphosis. So your COG lies in front of the thoracic spine in exaggerated thoracic kyphosis. Coming to the forward head, that is your cervical spine is moving forward, hence your COG lies behind the cervical spine. This is nothing but your forward head posture. Compare it with the normal posture. This is your good posture. Why am I dealing with the postural correction exercises in TOS? Any of the sway back, hyperlumbar lordosis, exaggerated thoracic kyphosis, forward head posture have all definite or indirect connection with the thoracic outlet because there is something known as articular linkage system. If your spine is affected, ribs are affected, outlet is affected. That is known as articular linking system. It is also a part of chandas. I'll be dealing in detail in the next video. Coming to the exercise protocol to be followed in stage 2. First one, shoulder exercise to restore the range of motion and so to provide more space for the neurovascular structure. Exercise is lift your shoulder backwards, that is extension, and up, that is abduction. Flex your upper thorax spine and move your shoulder forward, that is flexion, down, that is neutral. This is nothing but your shoulder exercise to be performed in order to reduce the neurovascular compression. This exercise is entirely repeated for 5 to 10 times. Coming to the second one, range of motion of upper cervical spine. Exercises lower your chin 5 times or 5 to 10 times against your chest while you're standing with the back of your head against the wall. The effectiveness of this exercise can be enlarged by pressing the head down by the hands. Coming to the third one, activation of scalene muscle. Though we have already seen that scalene it is undergoing hypertrophy or spasm, which can lead to compression of neurovascular bundle passing within it. But please remember that a tightened muscle is also weak compared to the normal muscle. But when a tightened muscle is compared to a weakened muscle, it is 20% stronger than a weaker muscle. Thus, in any cases, let it be your low back pain, let it be your knee osteoarthritis, let it be your thoracic outlet syndrome. In any cases, after releasing the tightened muscle, please make sure you activate it to the back to the normal recruitment pattern. Thus, activation of scalene muscle is also important when we are talking about thoracic outlet syndrome. The first one is put your hand to the side, compress it towards the sideways. This will cause activation of middle scalene. The same thing on the opposite side will cause middle scalene activation on the opposite side. If you put your hand in front and press your forehead against the hand, it will cause activation of anterior scalene. The same thing if your hand is placed behind, it will cause activation of posterior scalene. Coming to the stretching exercises, manual stretching and kinesio can be done for scalene, trapezius, and pectoralis minor, upper trapezius. Coming to the kinesio part, this is how the scalene tapping looks, this is how the upper trapezius tapping looks, and this is how the pectoralis minor tapping will look. Coming to the mobilization. Mainline mobilization is generally performed for shoulder girdle, that is your cervicothoracic, sternoclavicular, acromioclavicular, and costotransverse joint. The appendicular system, that is your shoulder girdle. Posterior, anterior, and inferior GH joint glides are also performed, thus in order to restore the glenohumeral movement. Coming to the last part, that is your operative options. Surgical release of scalene muscle and pectoralis minor is conducted if the scalene and pectoralis minor have undergone shortness, if there is presence of cervical rib, which is also an important cause for the thoracic outlet syndrome. Surgical excision of the cervical rib is performed. This is the end of the lecture. Thank you. We'll meet you all in the next video. Take care.